This week, it's a beautiful day, and before we start our proceedings, before we welcome our speaker, we'll start with a word of prayer. Can we rise up and... Our loving Heavenly Father, thank you for this beautiful day, Lord. Lord, as we get together for this session of Quest, Lord, we pray for you, to give us wisdom and knowledge through this session. Be with the speaker as he shares important information with us. Bless the whole institution as it walks forward this day. Be with our patients, our beloved students, faculty, and all members of the family of BCMCH. In Jesus' name we pray. Amen. Please be seated. Today we have one of our own stars, the professor and head of pediatrics, and my good friend, Professor Jijo Joseph John, to talk to us on the long-term management of bronchial asthma. And knowing Jijo, I know there's more. So let's put our hands together and welcome Professor Jijo Joseph John for this very important talk on bronchial asthma.
Morning all. I know it's too early for the crowd to come in, but thank you for coming in quite early. So today's talk is going to be on bronchial asthma in general. It is actually a talk is meant for the pediatricians who are practicing, but I'll try to address you as a common crowd also and see what is important as and when you see. Why this is important is because many a times you will be raised questions as to why your child should be taking, or somebody we know is on an MDI, is on a steroid, should we continue it? And you as a doctor should be the right person to advise why this is needed, what is needed. All these common queries you will definitely get if you have a child in your house, any of your friends, any of your relatives. If not now, in the future, definitely you will be facing these questions. So asthma in general in children is one of the most evolving fields as far as pediatrics is concerned. It's one of the only field where we talk every year what's new. For example, to put it into perspective, diarrhea treatment hasn't changed ever since I started in my MBBS days. That's been a long time. The same treatment we have been giving for diarrhea ever since. Asthma has changed drastically every year. There have been landmark changes happening every 3 years. There are guidelines coming up on a yearly basis. Evidence keeps on accumulating. What we said was wrong earlier has been changed. Science has been evolving as evidence comes. And possibly what I'm saying today will be different by the time you finish practicing, by the time you start practicing. So that's something which you have to keep on in touch with regarding devices, regarding the modalities, regarding each drugs being approved for different ages. So it keeps on evolving. Let's see where we stand at this point. Audible? Okay. So We have around 40 slides. So first thing when I listen to a speaker, I look at the number of slides so that I know roughly how long the talk is going to be. So we have around 40 slides, but we'll try to wind up as early as possible. Jacob, how much time do we have? Till half an hour's time. So let me know when it's half an hour's time so that I'll kind of wind up the rest of the path. Okay. So the roadmap for today, this is how we're going to go ahead. We will talk about a little bit about allergen avoidance, parent education, the goals of management, do's and don'ts at this point when it comes to pharmacotherapy. What are the age appropriate dosages? When it comes to children, the therapy is divided into 3 different ages: under 5, 6 to 11, and also anything about 11 becomes an adult-based therapy. And finally, what is a stepwise treatment when it comes to an adolescent? Also, when do we come down on therapy? What are the current guidelines? When do we stop treatment? In general, to call it asthma, it is a clinical diagnosis. It is a heterogeneous disease. It is a spectrum. Not all children who have asthma are going to behave the same. You will have your severe ones, you will have your mild ones, you will have your intermittent ones. And under 5 years, you don't use the term asthma. Children who are under 5 years of age, we don't call them or we don't label them as asthmatics because of the nature of illness. We rather call them, there will be a probability based diagnosis, wherein you will say this child is maybe an under 5 visa who has a low probability to progress to asthma or a high probability to progress to asthma. We decide on the probability based on how the child is presented. We use something called as a asthma predictive index or a modified asthma predictive index, wherein we ask for parental history of atopy. There is any history of multiple allergies. If the child has a parental history of atopy, multiple allergies, in the sense the child has allergic rhinitis, atopic eczema, atopic dermatitis, and asthma or visas or food allergy, these children are more likely to continue. They have a higher probability to become an asthmatic even after the end of 5 years. And the moment the child is above 5, we have our objective markers. You have a spirometry, you have a PFR, all these things we can objectively say the child has asthma or not. Now coming to treatment, most important things also include avoidance of allergens or irritants, parent or patient education to understand what the illness is, understand the chronicity of the illness, what is the natural progression of the illness, then pharmacotherapy, following which the patient requires a regular follow-up. What about allergen irritant avoidance? What are these? One of the most commonest allergen which is there across the world, which is a dust mite. So dust mite is one of the most common allergies. How many of you have dust allergy in this room? Can I have a show of hands? Okay. So dust allergy by far is one of the most common misnomer which is there, in the sense dust allergy is not a true allergy. It only tells you are atopic. It is just like saying I have a food allergy, but I am allergic to avial. I don't know the components in it. I could be allergic to one among the many components because dust in general is not uniform. Dust in this particular room will be the remnants from the walls, from your shoes, whatever it is. So what it tells you is you are allergic to one of those components. Dust mite is something what we see in your beddings, in your curtains, most commonly seen in your mattresses. It is microscopic, you cannot see it, it doesn't bite you, but it feeds on your dead cells, so it tends to be where you tend to sleep more. And it is not the live ones which cause the problems, even their excreta, even the dead ones which is there, will cause you to have problems, which is why many of you, if you wake up in the morning and have early morning symptoms, you are fine in the night, most likely you are being exposed to dust mite, and that is what is causing you problems. So how do you avoid it? These are all the things which can be tried, but at this point you don't have strong evidence to say they do work extremely well, but these are things which we advise. Avoiding all these things, warm water, changing the sheets. Another point is there are dust mite covers which are available abroad. We don't have them. We used to have them. At this point we don't have them in India now. They are expensive, wherein they are extremely small micropores, wherein even if dust mite is there, they don't tend to permeate out. That's one way out. Next commonest thing is going to be a cockroach. Cockroach again need not be a live one. It could be again the remnants. If you are allergic, you sleep in a room which had cockroach in it, you can have symptoms, especially allergic rhinitis. Next is going to be your mold or fungi, which is there when there is wetness, dampness, much more common abroad where you have wooden constructions more. you are much more likely to have fungi more. Then you have your pollens. Abroad, you do have your pollens, you do have your classical seasons. Nowadays, we have NRI patients coming in wherein they tell classically he was fine until it became spring or autumn. So that kind of clearly tells you these children have pollen allergies, wherein those pollens at that particular point cause them to have problems. Now, common question, can children who have allergies and asthma have flowering plants in their house? Yes or no? How many with yes? Okay, so I'm assuming everybody else is no. Okay, so one of the another common misnomer is regarding pollen is it is not the flower pollen which cause the problem. If you go back to your botany, you can understand the flower pollens. How do they pollinate? Insects. It is your vector pollination. So those are bigger, those are thicker. They do not cause you problems. They can act as an irritant. If the child picks up a flower, smells it, has an irritant reaction, yes, but not as an allergen. The ones which causes problems are the smaller pollen, which are finer, which are your grass pollen and your tree pollen. So they tend to travel with the air. And your humidity increases. You have a thunderstorm, your humidity, the amount of pollen counts increases. They tend to stay longer. So these are the things which causes problems. There are few trees which cause problems around us, but again, many a times you won't be able to change the environment. Abroad, you have a pollen count coming on a daily basis as part of your news. So abroad, when you have a very clear seasonal difference, when you know these are the pollen high levels, on those particular days, you ask the patients not to go for outdoor jogs, not to be outdoors in the morning hours, so that they tend to reduce their exposure to particular pollen. And by default, amongst the pets, cats are the ones which are more problematic than dogs. Many a times, if possible, it is better to avoid, but if difficult, at least keep them away from bedroom and remove the hair from upholsteries. Now, this is a child who came in, I think last week. One of the queries which the mother had is, the father loves dogs. Okay, the father loves dogs. The child is 3-year-old. The mother, he has recurrent wheeze. The father loves dogs. The dog stays in the bedroom. The mother's concern is this not the reason my child has cough? What do we do? So the answer to this query is, even though pets can cause, what you have to understand is, the question which you have to ask is, was this dog there before the child was born? Was the mother being exposed to this dog ever since the child, even in utero also, was the mother close to this dog? So what we're trying to say is, if the mother had, when the mother had the baby and she was still in continually proximity with the dog or a cat for that matter, the child will automatically get desensitized. It's very unlikely when a child is born and has been with the dog from the beginning, gets an allergy at 3 years of age. So a pet in general, it is good for a child to have. It definitely should be part of all families, but it need not be taken away just because a child is atopic. So it is better to prove the child has a problem with a particular pet to take it away from the child. Okay, so history becomes extremely important. So strict avoidance of everything without a detailed history will not make sense. So avoid smoking inside the home, including second and third degree. Third degree smoking is basically the grandfather telling, I don't smoke at home, I know my grandchild is there, I go out, I smoke, then I come back in. So I'm sure he's not exposed to smoke. So third degree smoke is what is the remnants which is present in the person's body, in his shirt, which acts as an irritant. So it is one of the good ways wherein you can strongly advise someone to stop smoking if your child is having an atopy or an allergic symptomatology. Environmental controls, yes, we are very clear as to environment plays a huge role when it comes to allergies and asthma. Our biggest pollution capital is still Delhi, so the number of cases of allergy, asthma is extremely high. Children having lung problems are extremely high. So you will have to make it a much more bigger way to cut down on your pollution. Vaccination, yearly vaccinations against flu, pneumococcal vaccination does have a role in reducing the exposure to viruses, especially the ones who are triggered by infections. Some of them do get triggered purely by infections also. Now, if you have a strong history, the children who did well during the COVID times, in the sense during the COVID lockdown, many of our children could stop medicines. That means they could stop their inhalers, they were absolutely fine. There was no problems at all for 2 years. Those children, the moment they started going to school, started having problems again. What the history suggests you is, these children do not have an environmental trigger. their triggers are mostly viral fevers, which is what they are getting exposed once they have started coming to the, once they have started coming here. One second. Hello? Questa mulla. Sorry, I was the CEO, so call is for the meeting. So coming back. So that is what the history tells you. So in those children, so always ask history which is relevant. At all points, whenever a patient comes to natopy, ask them, how were you during the COVID times? During the lockdown, when you're sitting at home, how frequent were your symptoms? Why is this important? Is it tells you one. Second thing, many times children avoid a lot of food items which can be restarted, which is easy for you to convince them. So if it was a food which is causing the problem, it should have caused problem during that time also. So at this point, since your child was well at that point, it's very unlikely the food which is causing problems. So parent education is going to be the nature, the need for treatment, the safety of the treatment modalities, make them understand that they do require intranasal steroids, inhaled corticosteroids, and talk to them about the fear of steroids. May address the fears. The commonest fears is, what are the fears of steroids? What are you scared about steroids about? Side effects of steroids, please. Growth retardation, 1. Obesity, cataract, immunodeficiency, immunosuppression. Okay. Now steroids in general are not the same. Steroids in general, they tend to be different. You have your, Jacob will be a better person to explain, you have your anabolic and catabolic steroids, and at the end of the day, it will all land up on final systemic absorption. So how much of the steroids actually reaches your systemic circulation, how much dosage of steroids the patient is getting, and how much duration is the steroids going on. So these are all the points which tells you as to, makes you decide basically what steroids are going to act. Now coming to your inhaled corticosteroids, to put things into perspective, on an average a child will get around say 200 to 400 micrograms per day. Suppose the child is getting say 200 micrograms per day. In a 10 kg child, if the child has an acute exacerbation, we tend to give say around 1 mg per kg. That means we give at least 10 milligram every day for 3 days. Now for 200 microgram a day, to become 1 milligram it takes 5 days. So it is divided, it is extremely microscopic doses. This is microgram versus milligram over there. And the systemic absorption is extremely less. The drug which reaches the lungs in general, even if you're taking the best method in your ICS, whatever way you take it, will be around 15%. That's all. The rest are going to be coming out through your expiration. Amongst the 15%, extremely less amount is going to come into your systemic circulation. It is locally acting. It's like applying an antibiotic cream versus taking an oral antibiotic. So these are different ways you have to understand what the patient understands and talk to them. It's a lot about communication, making them understand and alienating their fears. Talk about avoidance of triggers. Technique becomes extremely important. The most commonest errors children do is regarding technique. So technique has to be taught and it has to be repeated. Children tend to become smarter. They tend to try to finish it faster. So it has to be changed. Now coming to the goals, what do you want? What you want is good quality of life. You don't want patient to have an asthma attack. You don't want recurrent symptoms. The child should not have any dietary restriction. The number of children who come to our OPD with dietary restrictions because of asthma is extremely high. Understand children are picky eaters. Understand this is the age when children wants their diet becomes extremely important. You are talking about micronutrient deficiency. You're talking about protein deficiency. These children commonly are asked to stop milk, banana, eggs, many of the things which are regularly needed. Many of the times the allergy tests are wrongly interpreted. The tests are advised, the test will show positive to X number of foods. It doesn't mean the child is allergic to it. It only says the child is sensitized to it. So it have to have a detailed history and these children should not be stopped taking all these foods. I've had children who have come in at 8 years of age and have not cut a single birthday cake because the child was advised not to cut a cake because the cake can cause child to have allergic problems. And the child cut his birthday cake at the age of 8 years. So these are all common things which are happening. So diet restrictions does not have any role when it comes to asthma. No activity restriction. These children are asked not to play. They are advised not to go out because they tend to have cough. They are advised not to play. It reduces their confidence. It reduces their potential. You look at any sport of your choice, any sport of there is definitely an asthmatic who's doing extremely well in that sport. Just Google it, any sport. So it is such a common illness with the right diagnosis, right treatment. Everybody can do whatever they want. So children should have a normal childhood. That is your what treatment. That's what you want the treatment to be. And understand the child, when a child awakens at night, it is not just a quality of life of the child, it's a quality of life of the family also which gets affected. What do you want? You want to minimize asthma exacerbation, you want to minimize the side effects of medications, and also you don't want loss of lung function, which will happen. If you're not treating them, the inflammation will go on and the patient will end up in a loss of lung function. So key messages, ICS becomes your mainstay. Next thing is going to be your SABA is as required. Dose depends upon the age and severity of illness. Above 6 years is only when we start using LABA or long-acting beta-2 agonist. Children more than 12 years is treated like an adult. All patients should take an MDI with a spacer only. Even if you're an adult, you should use it only with a spacer. You should not be taking it without a spacer at all points. A mask is something which we advise at least for children at below 5 to 4 years. Above 5, it is on a case-to-case basis depending upon whether the child is able to do it or not. Now, things which are don't. Montelukast. How many of you have taken Montelukast in the last 1 month? Show of hands. Okay. And all of you have taken Montelukast as a combination? Agree? None of you have taken it as a combination. Okay. I mean, none of you have taken it alone. Okay, you've taken it alone. Now, Montelukast in general is a drug everybody is fighting. It is something you have to be extremely careful with the current era in prescribing, because earlier we used to say in the last 3 years during speaks as to not to use it. What's happening now is your social media is taking it up. You have a news report which had come in the New Indian Express actually a few days back. So there's a lot being written about it. I have started having patients who come back and say, why was my child prescribed this drug when this drug has so many side effects, and why was it not communicated to me? So this is where the problem is going to come. Now, with the era of social media, you have to be safe. If a drug has a particular problems, you should be informing, because tomorrow you will get sued for, even if the child has a mild symptom which might not be objectively, you will not be able to take it also. What are the problems? Nighttime awakenings, tremors, palpitation, anxiety. You can even have depression. Another rare symptom is going to be suicide ideations. Children who take Montelukast in the long run can have suicide ideations. Now, all these things which you talk about are under 2%. But if it's your bad luck, you are going to find that 2% children who's come to you for treatment. So abroad, it is a black box drug wherein you have to tell the parents, these are an extremely rare side effect told patients have seen. So if you are taking it, make sure you watch out for these symptoms. If you have these symptoms, stop it. Now think, if you're doing the same over here, which parent is going to take this medicine? Nobody will take it. So use it sparingly. Again, a combination is not FDA approved. Combinations have its own problems. If you think Montelukast combination is working for you, it is not the Montelukast which is working. It is the antihistamine which is working for you. You need an antihistamine separately. So stay away from Montelukast. Nebulizers is something which we strongly advise not to take at home. Parents do come and say, we have a nebulizer at home. It has been, nowadays it has become a family heirloom. It gets transferred from one family to another. My child under 5 years uses it very regularly. It is beautiful. You should also use it. Now my child is 8 years. Like how clothes are getting transferred from a bigger child to the younger child. Now the nebulizer gets transferred from one house to the next house. But we strongly advise against it. Reasons being is, one is patients do tend to get hypoxic when they have an asthma attacks, which will be missed if they continuously take nebulizers at home. One. Second thing, drug wastage is much more higher, especially when you're giving steroids. You can have an eye deposition much more higher. Third thing being said is, they are rarely cleaned. Nebulizers are meant for single use. You should not be using from one patient to the next patient. Okay, they are rarely cleaned. These are aerosol producing problems. We stopped nebulization during COVID times because they were producing aerosols which is spreading. So you have a child with viral fever sitting at home, taking an aerosol, and everybody walks in and out of the room. You are literally giving it to everyone in the whole family. So that is one. Third thing is going to be is they're not cleaned. Once they're not serviced, they're not cleaned. They then in itself can harbor infections. So that in itself, it is a source for infection also. So strongly discouraged. About 6 years at this point, this is something which has changed. Earlier, if a patient had mild symptoms, it used to be only SABA or your salbutamol as and when the child required. What has changed is now they have stopped advising it. Even if the child has intermittent symptoms, you have to give your steroids also for a short term. Why this change has happened is asthma deaths still happen. Even abroad, in the most developed nations, asthma deaths still happen in children, UK, US also. Why this is different is, what has changed, what they have understood over there is, patients come during the initial stage. Patients come to the ED, they receive a salbutamol nebulization, they are sent home on salbutamol. The next time when the patient gets an attack, they take salbutamol again. This circle continues. So the patient who has mild asthma can progress to a severe asthma later. He can have an attack later. So once this keeps on progressing over a period of time, when you keep on taking beta-2 receptors, it will not act longer. Beta-2 receptor only opens up. It is not working on the inflammation. So these children, they tend to try it on for quite some time. By the time they reach the ED, they are already shut down completely. And the facilities becomes, even if with the best facilities, children still die with asthma, adults still die with asthma in the developed countries, which is why they have told, whenever you're using SABA, give your inhaled corticosteroids also, so that even if they are self-using it, they will take, the ICS being part of SABA will take care of the inflammation. At this point, you have a few solutions which are coming in as a combination of budesonide, steroids with salbutamol as a single respule. Those combinations have not been approved yet. Soon we will have a scenario wherein it is going to come with salbutamol. I mean, it will approved ones will come in wherein the salbutamol itself will stop and you will only have an MDI or a inhaled solution which has both of them together. That will kind of solve the problems in the longer run. Let's see how it goes. Now, more than 5 years in mild years, so always use it with ICS. Now, MART is something which has come in, I think around 4 years now, which has changed the therapy of asthma completely and it has made it much more easier. MART basically means a single inhaler which can be used both as a maintenance and as a reliever. So patient goes back home on a single inhaler. So this is, if each and every one of you have asthma or intermittent symptoms, you should be doing this. Just have a MART with you. What is MART? You have a combination of budesonide with formoterol. This is what you should be taking. And budesonide formoterol, about 12 years, what will be advised is use, it is a combination of 200 microgram of budesonide and 6 microgram of formoterol. That's what the fixed combination which comes in. You take one puff whenever you have symptoms, if you are a mild intermittent patient. Or if you are on a regular therapy, you take one in the morning, one in the night, and you take one more whenever you have cough, shortness of breath, or any of the allergic problems. Now, how many can you take? You can take up to 12 puffs in 24 hours. In children about 12 years and all of us adults. So this is going to be a simple way of each of us, if you have to advise treatment for any of your friends, family, regarding having asthma, they're not been on anything else, at least start them on this. Okay? How does it work is because formoterol also is a FABA. FABA is a fast-acting beta-2 agonist. Remember, MART can be used only and only with budesonide formoterol combination at this point. You cannot use MART with salmeterol. Salmeterol acts only as a LABA and it is not a FABA. So how do you decide? Everything is stepwise based upon the patient's response. Understand the dosages. Let's focus only on budesonide. Others are not easily available. Budesonide is going to be low total dosage, is going to be 200 microgram. So you get a puff which is of 100 microgram. Use it one in the morning, one in the night. That's good enough. So any child becomes a bigger or older child. Low dose is going to be 100 puff once in the morning, once in the night. Medium is going to be 200 microgram puff once in the morning, once in the night. Leave the high dose. You should not be giving high dose to children. If you're giving high dose, it's better a specialist handles it because you might be missing out on something. Under 5 years, this is what we follow. It will be a child who has infrequent viral wheezing. That means only when the child has viral fever, he has symptoms, maybe once in a month, once in 2 months. you do what we see, what is given is as and when required, the child takes a salbutamol. Again, remember levosalbutamol versus salbutamol. No difference. Theoretically, levosalbutamol works better, lesser side effects, but no guidelines at this point mention levosalbutamol over plain salbutamol. Plain salbutamol is good enough. There is an age cutoff for levosalbutamol. You should not be using it below 6 years of age. So levosalbutamol at this point, FDA approval is only for children above 6 years of age. So intermittent symptoms, you use salbutamol, and you look at your other control options. ICS can be added in the onset of viral. This is what I practice. Whenever the child has symptoms, the child takes salbutamol, and ICS is continued for a week or a max of 2 weeks based upon the child's need. Whenever you advise a child to be on salbutamol, it is ideal the child follows back with you at the end of 2 to 3 days, because you can assess and tell either increase or reduce the medicines. So whenever you are telling the patient, വീട്ടിൽ മരുന്നും കൊണ്ട് പൊക്കോ, ചുമയുള്ളപ്പോൾ സാൽബുട്ടമോൾ കൊടുത്താൽ മതി, 2 പഫ് വെച്ച് എല്ലാ 2 മണിക്കൂറും കൊടുക്കാം. പക്ഷേ 2 ദിവസത്തിലേറെ എടുക്കേണ്ട വന്നാൽ ഞാനോ ഒരു പീഡിയാട്രീഷ്യനോ കണ്ടിരിക്കണം. കാരണം you will have to reassess a child to see if the child requires an oral corticosteroids. Cough is just a symptom. It is not an illness. So you will have to understand what is causing the cough and accordingly change your treatment. Second one is, if you decide the child has multiple symptoms, but under 5 you can't prove the child is having asthma. So wherein what do? You start a therapeutic trial, wherein you say, let's put you on an ICS for 3 months, see how you're doing. If you're doing better, definitely you are an atopic child, or there's no reason why you're better. So that's where you're going to start. What is a pattern that is consistent with asthma? That means recurrent cough, bronchodilator reversibility, child gets better on nebulizer, better on salbutamol solutions. Child tends to be more symptomatic during the night. Child has in your history, when you ask them, they have emotional triggers which causes them to have cough. That means ചുമ കൊച്ചു കരയുമ്പോഴോ ഒത്തിരി ചിരിക്കുമ്പോഴോ ചുമയ്ക്കാറുണ്ട്, കുറേ കളിക്കുമ്പോൾ കുട്ടി ചുമയ്ക്കാറുണ്ട്, ഓടുമ്പോൾ ചുമയ്ക്കാറുണ്ട്. These are all exercise induced bronchoconstriction. This is all the history which we trying to take. Third thing is, children who have done a trial and they're partly controlled, they're not doing well, wherein you double the dose of ICS. That is the only place where you will consider adding a Montelukast. Montelukast doesn't come before that. It can come in step 2, but again you have to be clear with the parents, communicate, and only then start at this point. And finally, if it doesn't get better on double dose of ICS, that is 200 microgram BD budesonide, child is not better, make sure a specialist sees his child. So at all points, anytime a child comes in, always look at the technique, the adherence, whether they are actually taking it or not, whether there was any exposure of triggers at that particular point. There is വീടിന് പണി നടക്കുക, പെയിൻറ്റിങ് നടക്കുക, കാർപ്പൻട്രി നടക്കുകയാണ്, അപ്പോൾ റോഡ് പണി നടക്കുകയാണ്, ഫാക്ടറി തൊട്ട് വന്ന് പുറത്ത് തീയിട്ട് കത്തിക്കുന്നുണ്ട്. There are multiple things which you will get from your history. There is a new pet in the house. They have bought a new fur toy inside the bedroom. Their bed sheets have changed. A new furniture has come. Furnitures have something called as VOC or volatile organic compounds. There are a lot of things which will come in your history as to why this child has an exacerbation. Child has just joined school. No, there's a sibling who has joined school, and child is a younger child. So there are multiple things which comes in your history for you to be sure why this child is having that problem at that particular moment. So simple case, 3-year-old child, recurrent cough once in 1.5 to 2 months, starts with a cold, then a chesty cough for 10 to 14 days. Cough is worse at night, not completely well between episodes, coughs occasionally on exertion and crying. There is history of dyspnea or cough which gets better on nebulization with salbutamol. There is eczema history in the infancy. On family history, there is a history of asthma in the father. On examination, there is bilateral wheeze on auscultation. Physician diagnosed wheeze is of more importance than a parent reported wheeze. Many times what the parent reported wheeze need not be wheeze. It mostly കുറുകൽ എന്ന് പറയുന്നതാണ് നമ്മുടെ നാട്ടിൽ പറയുന്നത്. അത് usually it is your nose block. It need not be a wheeze per se. So many times you have to be sure this is a physician diagnosed wheeze. So what do we ask in the history? Doctors just എത്ത് വെച്ചിട്ട് ഉള്ളിൽ കപക്കെട്ടുള്ളതായിട്ട് പറഞ്ഞിട്ടുണ്ടോ, വീസിങ് ഉള്ളതായിട്ട് പറഞ്ഞിട്ടുണ്ടോ? And if it correlates, fine. Or if it is documented, extremely good. So in such a case, where do we go? The choice is going to be over here, and we'll see how the child is doing. Now, this is going to be a rough prescription which you should be putting up when you are writing a similar case, wherein you write your main points and you write as to what is required, what is your diagnosis, and what is your plan. and clearly write how the prescription should be. Once in the morning, once in the night, again for how long. Salbutamol, again, what is the color? You have to be very clear as to how the patient should take it. How should they clean the spacer? When should the next review be? And accordingly, you'll have to plan further. Understand many a times what the patient wants more than anything else is to talk to you. They want to raise your concern. They want to make sure they tell you each and everything which is a concern of them. So many times when you have a first case of asthma, you should be seeing them as your first patient. You should have to allot them 15 to 20 minutes or else you won't be able to do them justice. And you will have to modulate your counseling as per the patient's education, as per the patient's need, and divide it into different parts. You need not tell them everything in your first sitting. You have to divide it into different parts so that at each visit you re-emphasize or give an extra knowledge as and when they come. Now this is what we follow in children above 6 to 11 years. Symptoms less than twice a month, ICS as and when the child has symptoms. Symptoms more than twice a month but not daily. Daily low dose ICS. Then symptoms are most days but child does awake more than once a week. Wherein you go for, it's a little complicated over there, we'll talk about that later. And then step 4 is going to be symptoms on most days or night awakening more than once a week and a low lung function. So children more than 6 years always get a spirometry done because your step 4 depends upon your spirometry. So you should always get a spirometry done. Step 5, forget it. Patient requires step 5, send him to a specialist, don't think about it. Now in this child, 8-year-old child, father reports troublesome cough every other day. Cough leads to nocturnal symptoms. No history of cough on exertion, but directly questioned child does say activity limitation. He doesn't go to play. When he plays football, he is always the goalkeeper because he is worried about running, which causes him cough. So he has decided to be part of the thing. He will always be the goalkeeper. And he has received multiple times antibiotics, feels better but on nebulization. Every fever he goes to the close by hospital, he gets a course of antibiotics, but he does feel better only when he takes a nebulization. No family history of atopy. When you ask, V's is there. When you do a peaked PFR, after bronchodilator, there's a response by more than 20%. That means you ask him to blow into the peak flow. You give him salbutamol 2 puffs, you ask him to repeat after 20 minutes, there is an increase by more than 20% of where you started. Where does a child fall? Child falls into step 3. It could also be step 4 also, but step 3 is where he falls in. Now in step 3 you have 3 options. One is your low dose ICS LABA, which is going to be in a child under 12 years. ICS LABA as a MART therapy starts only on step 3. It is not your step 1. So step 3 over here the dosage difference is going to be in an adolescent it is 200 microgram while over here it is 100 microgram of budesonide and you will not use it for more than 8 puffs. Now you have 2 choices. One is you keep your budesonide formoterol as your daily controller. You use your salbutamol as and when the child has symptoms. Second option is you increase your budesonide to make it 200 microgram BD and use salbutamol as and when required. The last one is what we talked about, a very low dose ICS LABA, which is budesonide formoterol at the night as a single dose, and you use the same puff up to 8 times in 24 hours. You have all 3 options which is viable. You can decide based on what the patient already was on and what he showed response as. So you have 3 options over here. Now in this child, this is how we decide to go ahead. Remember, this is an easy way for you to write a prescription or a small case history when you're seeing a child in your busy OPD, wherein you talk about the most important points, talk about you clearly mention what your diagnosis, write in detail what your treatment is. All patients who are on inhalers, especially budesonide or ICS, they have to gargle after they use it or at least drink a glass of water, because you can have oral deposition which is reduced a lot when you're taking it with a spacer, but this is how we should go ahead. Case 2 continued after 1 month of therapy. Child is still better, but he still has cough daily. He needs to use reliever almost daily in the afternoon after she returns from school. Also at this point the child gives history of a runny nose, bouts of sneezing and an itchy nose in the most mornings. Now you know her asthma is only partly controlled. You are expecting a better response. The child has not reached here. What is the most commonest thing? What the history is? It is allergic rhinitis. By far, the most commonest comorbidity in asthma is allergic rhinitis. To put numbers in perspective, say around 40% of children who have asthma have allergic rhinitis, and around 40%, 60% of the children who have asthma have allergic rhinitis. 40% of all allergic rhinitis will have asthma. So they go hand in hand. So it is a unified airway. Unless your nose gets better, your chest is not going to get better. So you will have to address it. Allergic rhinitis has to be treated. These are the 4 things which we ask, the cardinal symptoms of allergic rhinitis. മൂക്കൊലിപ്പ്, തുമ്മൽ, മൂക്കടപ്പ്, മൂക്ക് ചൊറിച്ചിൽ. ഇതിലേതെങ്കിലും ആഴ്ചയിൽ 4 അതിലേറെ ദിവസങ്ങളോ ഉണ്ടെങ്കിൽ ഇറ്റ് ബിക്കംസ് പെർസിസ്റ്റന്റ് അലർജിക് റൈനൈറ്റിസ്. ആഴ്ചയിലെ ഒരിക്കലേ ഉള്ളൂ, അല്ലെങ്കിൽ 2 ആഴ്ച കൂടുമ്പോഴേ ഉള്ളൂ. പക്ഷേ ഉള്ള ദിവസം നല്ല ബുദ്ധിമുട്ടാണ്, ജോലി ചെയ്യാൻ പ്രയാസമാണ്, ആൻറ്റിഹിസ്റ്റമിൻ എടുത്ത് കാണാൻ, ഉറക്കം വരുന്നുണ്ട്, ക്വാളിറ്റി ഓഫ് ലൈഫ് അഫക്റ്റ് ആവുകയാണെങ്കിൽ ഇറ്റ് ബിക്കംസ് moderate to severe. Anything else becomes mild. The treatment is going to be inhaled nasal steroids, antihistamines as and when required, only in patients who have intermittent symptoms or mild symptoms. Anything else requires inhaled nasal steroids. So in this child receives treatment for both. He got an inhaled nasal steroids and he got better. Now, when it comes to children about 12 years and adolescents, this is the guideline which is given. These are all part of the GINA guidelines. Now, over here, what has changed is, make it simpler, you have 2 options. One is what we talked about. You start off, when a child have intermittent symptoms, you start off with low dose ICS and formoterol, which is your budesonide formoterol, as and when the patient has symptoms. Similarly, it is what is called as an anti-inflammatory reliever, as in whenever the patient gets a reliever, he also get an anti-inflammatory effect from the ICS the patient also get. Okay, this is what a MART therapy. Next one is, if you don't want to follow it, patient gets SABA and ICS as and when child requires. Next step is going to be is step 1 and 2 symptoms, that is symptoms for which is less than 4 to 5 days a week. Those ones also are doing well on SOS ICS with formoterol. If the symptoms are less than 2 times in a month, over there you can use SABA with ICS. You can choose any of these. For ease, I would say stick to track 1. Track 1 is symptoms. For step 1 and step 2, use your ICS with formoterol as and when patient has symptoms. The moment the patient has symptoms on most days or are waking up with asthma more than once a week, patient goes into a low dose maintenance. That means ICS LABA is given once in the morning, once in the night, and the same is asked to be on SOS basis also. Okay, and as the patient goes up, your dosage of the same goes up, and anything beyond that, poor control of step 4, other things will come up, like tiotropium, all those things will start coming up. At those point, it is better the patient goes under the specialist. So stepping up dosages, whenever you're stepping up, understand whether the patient is doing it, taking it at all from the first place, the technique is proper, the comorbidities are addressed like allergic rhinitis and GRD. Environmental triggers like exposure to cigarette smoke, indoor, like we talked about earlier, all of them are addressed. Now, this video, I'm sure all of you have seen it. So we'll just play it one more time.
She said they fixed it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes.
So particularly she says is my asthma was supposed to get better. They told they'll fix it, never got better. And house asked, how do you take it? She asked, are you using the inhaler? She said, I use it every day.
Do I look like an idiot?
No. But you show me how your inhaler works.
She's asked to demonstrate the technique. So this is one of the, we can give you stories as to how many times the patients make errors at the different ways it will take. The commonest things which we see, which I would say, one is they shake the inhaler, they put it inside, they put the puff in the air, and then they take it. That's one. Second commonest error is going to be they shake it, they put it in, they'll press it, and the child starts having a race. He's going to go like, we would ask him to take 10 breaths, he'll finish 10 breaths in 1 second. So it's, as far as he is concerned, the 10 breath, the number is in his head, so he tries to finish it up as fast as possible. So how to take it becomes extremely important. I hope we have the devices here to show the technique. So simplify things. The best way to take it in an adult is going to be is you exhale out, you keep the inhaler close to your mouth, and when you're after taking it, that is always with a spacer, you take it, and after it is given, take a deep breath, hold your breath for 10 seconds, and slowly breathe out through your nose. In children, within adolescents also, we advise them to take 2 breaths, because what we have seen in practice is, even if we say 1 breath, many times the errors are much more higher. 2 breaths, at least 1 breath will go properly, at least the first breath goes properly, but even 1 breath is good enough. In a child who's below 12 or he cannot hold a deep breath, wherein we advise them to hold as much as possible, 5 good breaths as much as possible, and breathe out slowly. The third one is going to be a smaller baby, say a 1-year-old or a 2-year-old baby who doesn't understand, who can't take it, wherein you have to be sure the child has a normal breathing. Normal tidal breathing for say around 10 breaths, 30 seconds is good enough for the drug to deliver. But the best is going to be the child be able to hold the breath. The commonest errors which we see is smaller children, the parents tend to hold the child tight and try to give it. The child tries, child moves her head away, the medicine hardly goes. In a crying child, it's an expiration process. Half of the medicines are lost because the child is crying. So what we do advise is make sure the child holds it, gets comfortable with the spacer. You make it a play therapy, keeps on the mother's face, keeps on the child's face. The child is used to it, and only then you advise them to start the therapy. Once the child is scared, you're going to take a month before you start using it again. If it is a crying process, soon the grandparents are going to get involved and say, okay, stop taking this. You're making the child cry. This is not needed. So make sure the child is always comfortable. Third thing is going to be is when the child sleeps. Parents tend to give it when the child is sleeping. Again, the problem is going to be when you're sleeping, your respiration is kind of shallow. So you need a deeper inspiration for your drug to reach. So when your inspiration is shallow, you will not get your ideal scenario what you require. So at all points, whenever child is not getting better, you have to go through this circle. You assess, you adjust, and review response. Now, it's always important that whenever you're prescribing, it should be for at least 3 months or to continue. Even when you write for 3 months, what happens? Even after all these stories, they'll come up after 9 months and say, we were better when you told us the medicine. We took it for 3 months, exactly what you advised. Then we stopped it because the medicine got over. So at all points, whenever you're advising, you should say, this is for 3 months, but stop it only after you meet me. Do not stop it without meeting a pediatrician, because we'll have to assess your level of control to decide whether you need to be on it longer or not. Another common question the parent asks is, if we take an inhaler, this is lifelong. Can we never be off it? Now, your movies are your biggest culprits, where only the villains have asthma, and many times villains die because they don't have an inhaler in their hand. So their parents tend to think if the patient doesn't have an inhaler, at some point he can be at very high risk for death. So it doesn't work that way. So what you have to tell them is, think of it as a good habit. How many of you have glasses on? If many of them are using this medicine and are doing better, you tend to continue it till they need it. Once they're better, you can take it off. Think of it as a good habit, something like brushing your teeth. You brush your teeth because it has an effect, makes you better. Similarly, these medicines have to be on as per the child's need, and also understand the same medicine has different roles. For example, many of them will say, my grandmother was on it, she died because she used an inhaler. Now, that is not the fact is. The fact is your grandmother was on inhaler for a very different reason altogether. She might have been a COPD, she might have had lung cancer, she can have multiple things wherein the same medicine might be advised. So make them understand how childhood and adults work differently. And always have a written asthma action plan so that they understand what they're supposed to do. 13-year-old child, now we'll speed up, it's 9:15. Where do we put such a child case in? The child automatically falls into daily symptoms, waking due to asthma once a week, low lung function, child falls on this. This is how we're going to advise this child as a MART therapy, as and when the child requires. This is how we'll be giving the written prescription. So what are the things which you ask? This becomes important. When a patient comes back to you at the end of 1 month, in the last 4 weeks, this is your asthma control which you ask to know where the patient stands. Your treatment is decided on where the patient stands, which is it a well-controlled asthma, partly controlled, or uncontrolled asthma. Based on this, you will decide, you will assess, reassess, look at the adherence to decide whether you have to step up or step down. Now, this is something which is commonly not followed. wherein you have to know that this patient is following up with multiple doctors and this patient has been receiving multiple medicines over a period of time. This is a longitudinal way of looking at what all the medication the child has had over a period of time, so that you understand where you stand, not just based on just 1 month symptoms. Why is this important? Is you want to reduce the oral corticosteroid usage or rescue medication usage. If a child uses more than 2 to 3 in a year, or the child it's a red flag. If the child uses more than three oral corticosteroids in a lifetime, the child is on a higher risk for osteopenia, diabetes, and multiple issues in the future. So you don't want it to be as less as possible. So when do you step down? It based on the last how controlled the symptoms are and what are the future risks. If the child requires ICU admission, child is required goes on the ventilator, you are going to be a little bit careful before you step down. Look at the risk for exacerbations in the coming few months. You will not step down before the schools are reopening. You will not step down before the winters are coming. You will not step down before Christmas. You won't step down before Diwali, because firecrackers. When you know pollution is going to go up, this child can have an exacerbation, you will be a little careful without stepping down. These are all the things which we started. Look at how the child is before we reduce. If the child is well controlled for 3 months and there is no immediate risk of poor outcome, you step down. How do you reduce? 50% reduction in the ICS. That means if you're using a 200 microgram puff once in the morning, once in the night, you make it 100 microgram twice. And whatever step down you're doing, you will reduce it and wait for 2 months to see how the child is doing and then further reduce. ICS LABA, you reduce it by 50% while continuing LABA. That means 200 microgram of ICS plus LABA is the child is on. We come down to 100 microgram ICS plus LABA, and then we go to 100 microgram ICS alone, and then maybe require to switch to OD and then stop. This is in general as to how the stepping down is usually done. So when do you stop the treatment? You stop when the patient has good control and no activity limitation. Child is living a normal life for 6 to 12 months and there's no risk factors. You stop daily controller. You advise them, trigger advice. You give them a written home action plan as to if the child, even if the child is better, the child can have an attack in the future. You maintain a symptom diary for at least a year, and at all points, initially at least, you call them back every 2 to 3 months. Counsel regarding possible future resumption of controller if it recurs. Just because it has stopped now, in a new environment later, you can have further recurrence. So you have to keep the children under close follow-up. As we talked earlier, asthma has been evolving across the years. Things which you spoke today might not stand true in the years to come. So at this point, how are things changing? It is moving more towards individualized treatment strategies. Biologicals are coming up in a big way. You have more and more newer devices. You have breath hailers in, which I advise each of you, if you are on an MDI, strongly advise you to use a breath hailer wherein you don't need a spacer. The acceptance is higher. Chance of errors is extremely less. So this is where we are at this point. Things will change. Your immunotherapy is coming up. Let's see how it goes into the future. Thank you.
Thank you, dear Jijo. That came as a fresh breath of air in the midst of all the asthmatic suffocation. Thank you. So, any questions? Any questions, dear friends? Jijo, what about alternatives to Montelukast?
Again, alternatives in the sense is your ICS is what you're going to be mainstay. Now, if you have looking at alternatives, Montelukast at this point, can be advised for asthma or allergic rhinitis. In allergic rhinitis, in the intranasal steroids is your mainstay, and your antihistamines as and when required. So Montelukast doesn't come in over there. ICS again works better than Montelukast. So if you're using Montelukast intermittently, you're mostly using it for allergic rhinitis. So intermittent Montelukast won't have any role. You'll be equally benefited if you're using it with your plain levocetirizine also. At this point, I will use the word abused more by ENT more than pediatricians, wherein we tend to see children on Montelukast levocetirizine combination for months, 6 months, 1 year, which is a very erroneous practice, and there's not much evidence at this point. So that is something which we commonly see. So you have safer, better alternatives which act better. The only advantage Montelukast has is the ease of taking it. It's a tablet or a syrup versus taking an MDA or an intranasal steroid. That's all.
With respect to inhaled ICS, you spoke about eye deposition.
Yes.
How far is it a
So
problem?
eye deposition usually happens when you're taking a nebulizer. It doesn't happen with your ICS with your regular with your spacer or with a mask. Eye deposition doesn't happen. If a child tends to take ICS regularly as a regular therapy instead of using only a nebulizer, eye deposition is an issue. Cataract is something which is a rare possibility but still possible. But that is something which we strongly advise not to use nebulizers regularly.
Thank you, Jijo. What is the role of xylutin?
Xylutin was there earlier. At this point, it is not there. All xylutin, neodochromal, all those guys have moved out. Even your Safri-Lucas also, which again brother of Monty Lucas, none of them have had. They were all promising drugs. They would always be on the lookout for oral drugs to control asthma better. But at this point, we have all moved back. So there was a time when we spoke about Monty Lucas highly when it came in. All the side effects came in were all post-marketing. They were not there when the drug was launched. After it was widely used, that's when all the issues have crept in.
Thank you, Jijo. Any other questions, please? If not, we'll thank Dr. Jijo and we'll wrap up for the day. Thank you all. Thanks for coming.
Thank you.